Welcome back to the deep dive. Today, we're taking a really close look at our body's security system. We're talking immunity and inflammation.
Yeah, and we're sticking strictly to our expert medical source text for this one. The idea is to give you a clear step-by-step summary.
Exactly. We'll cover the core concepts, the pathophysiology, what signs to look for, the clinical manifestations, and importantly, the nursing strategies right from the text.
Our mission, really, is to help you get a solid handle on these three big interconnected ideas: immunity, inflammation, and infection. Understanding how they relate is just foundational.
So let's start with maybe the biggest challenge for the immune system. It's not just fighting invaders, is it?
No, not at all. It's fighting them off without causing friendly fire, without damaging our own healthy tissues. That's the concept of self-tolerance.
Self-tolerance.
Okay.
Really tell us from them.
Precisely. The system has to recognize healthy self cells and differentiate them from, well, non-self things like viruses, bacteria, or even cancer cells, transplanted tissue.
Okay, so how does it do that? How does the body, label its own cells?
Yeah.
Put that universal product code on them.
It all comes down to human leukocyte antigens, or HLAs. These are unique proteins on the surface of almost all your cells. They're genetically determined.
So like a fingerprint for your tissues.
Kind of, yeah. Think of it as your body's ID card. If an immune cell bumps into something and that HLA doesn't match your specific code, it's flagged as foreign.
And the alarm bells go off.
Instantly. And the defense kicks in. That's why HLAs are so incredibly important in areas like organ transplantation. You need that match.
Right. So when everything's working smoothly, recognizing self, fighting invaders, we call that person immunocompetent. They've got maximum protection.
And that protection machinery, it all starts in the bone marrow. Every defensive cell, the leukocytes, your white blood cells, they originate from stem cells there.
Okay. And the text highlights three key processes needed for full protection.
That's right. First, you've got the general immediate actions of inflammation. That's part of our innate immunity. Then you have the two specific learned responses: antibody-mediated immunity, or AMI.
And cell-mediated immunity, CMI. You need all three working together.
Absolutely. Let's kick off with that first line of defense: innate native immunity. Some call it general immunity.
This is the fast one, right, but not very specific.
Exactly. Immediate, short-term, but it reacts the same way to any kind of threat. It includes your physical barriers like skin and mucous membranes.
And the good bacteria, the microbiome.
Yep, that too. Plus antimicrobial chemicals, things like complement, and of course the inflammatory response itself. When something gets past the barrier, inflammation starts.
And the first responders arrive on scene.
The neutrophils. They flood the area. They're the most numerous WBCs, making up, 55%, 70% of the total count?
A huge percentage. And their job is pretty straightforward.
Destroy invaders, especially bacteria. They do this through phagocytosis, basically engulfing and digesting the enemy.
Okay, phagocytosis. And this brings us to something really key for patient safety: the absolute neutrophil count, or ANC.
Right. The ANC directly tells you how well a patient can fight infection. But what's really interesting and clinically vital is what happens when the infection is overwhelming the system.
Ah, you're talking about the left shift. Bandemia. What did that actually signal when you see it on a lab report?
It signals serious trouble. It means the infection is severe, it's ongoing, and the bone marrow can't keep up producing mature neutrophils, the segmented ones, or SEGs.
So it starts pushing out immature ones.
Exactly. The banned neutrophils, they're like sending teenagers into battle because you've run out of trained soldiers. It's just not fully capable.
Minimally beneficial, as the text says. So a left shift isn't just infection, it's the body struggling to cope. Risk of sepsis shoots way up.
Definitely. Because those bands can't clear the pathogen effectively. So keeping an eye on the ANC and watching for a left shift, that's high priority safety stuff.
Absolutely critical. Now, you mentioned phagocytosis, the engulfing process. There are 7 steps, but you highlighted one as particularly important.
Adherence. The phagocyte has to actually stick to the target. And this is often helped by substances called opsonins.
Opsonins. What do they do? Like making the target easier to grab.
Pretty much. Think of them as molecular Velcro or glue. Opsonins, they could be dead neutrophils, antibodies, complement fragments. They coat the bacteria or whatever the target is.
Makes it less slippery.
Yeah, gives the phagocyte something to grip onto, makes adherence and then ingestion much more efficient. Opsonization is a great example of immune system teamwork.
Painting the target for destruction. I like that.
It works.
Okay, so that's the cellular battle. Let's zoom out to what we actually see clinically. The text says, all inflammation, no matter the cause, splinter, burn, infection, it follows a pattern. 3 stages.
And it produces those 5 cardinal symptoms: warmth, redness, swelling, pain, and decreased function. Always those 5.
It's kind of it's so predictable. Stage I is the vascular response.
Yeah.
What kicks that off?
Injured cells release chemicals, histamine, serotonin, kinins. These cause small veins to constrict, but crucially, arterioles to dilate,
Dilation means more blood flow.
which causes the redness and warmth. That's called hyperosmia. At the same time, those kinins make capillaries leaky. Plasma escapes into the tissues.
Leading to the swelling, the edema,
Oh.
and the pressure causes pain.
Exactly. And even in this early stage, the macrophages are busy. They release colony-stimulating factor, CSF.
The signal back to base.
Yep. Tells the bone marrow, we need more troops. Ramp up WBC production.
Okay, then stage 2. Cellular exudate. This is when the reinforcements really pour in.
Massive influx of neutrophils, it's neutrophilia, and this is when you see exudate or pus. It's basically dead WBCs, dead tissue bits, fluid, the debris of battle.
And the inflammation keeps going.
Yeah, this is where the arachidonic acid cascade gets going. It converts fatty acids into things like prostaglandins and leukotrienes, which keep the inflammation sustained until the job's done.
But this is also the peak danger zone if things aren't going well.
Right. If that left shift we talked about is happening, stage 2 is when the sepsis risk is highest.
Got it. Then finally, stage 3 is tissue repair and replacement. And this actually starts right away.
Kind of surprisingly, yes. It begins at the time of injury. If the damaged tissue can regenerate, like skin cells, WBCs signal them to divide and repair.
But what if it can't? Like heart muscle after a heart attack.
That's the crucial point for long-term outcomes. If the tissue can't divide, the body forms scar tissue. It triggers new blood vessel growth, sure, but fills the gap with scar.
And scar tissue isn't functional tissue.
Not in the same way. So wherever significant scar tissue forms after a heart attack, a severe burn, chronic inflammation, you inevitably have some loss of function in that organ or area. That's the price.
A permanent consequence.
Okay.
We've covered the immediate general response. Let's switch gears to the more sophisticated side. Adaptive immunity.
The acquired immunity, this is specific, creates memory and gives us long-term resistance. The body has to learn the enemy.
And it has 2 main branches.
2 main arms, yeah. First is antibody-mediated immunity, AMI, sometimes called humoral immunity. This relies on B lymphocytes, the B cells.
And B cells make antibodies.
Exactly. Specific antibodies or immunoglobulins that circulate and target specific antigens.
How does that process work? Making the right antibody for the job. It's not instant, right?
No, it takes steps. First, exposure to the antigen. Then, crucially, antigen recognition. This actually needs help from macrophages and helper T cells to process and present the antigen to the B cell.
Teamwork again.
Always. Once the B cell recognizes it as foreign, it gets sensitized. Then comes a really key step that sensitized B cell divides.
Into 2 types of cells.
2 types. You get plasma cells, which are the antibody factories starting production right away, and you get memory cells.
The ones that remember the threat for next time.
Exactly. The plasma cells release antibodies into the blood, the body's humors, which is why it's called humoral immunity.
Yeah.
These Y-shaped antibodies then find and bind to their specific antigen.
And what happens once they bind? How do you neutralize the threat?
Several ways. They can cause agglutination, clumping the antigens together, making them easier to clear, or precipitation, forming big complexes that fall out of solution.
Filming up the works.
Pretty much. Or inactivation, just covering up the harmful part of the antigen. Sometimes, for tougher targets, the antibody binding triggers the complement system cascade, leading to lysis blowing holes in the invader's membrane.
Direct destruction. But the real power for the future is in those memory cells.
Absolutely. On re-exposure, maybe years later, those memory B cells kick into high gear immediately. They produce a huge, fast antibody response, the anamnestic response.
Often stopping the infection before you even feel symptoms.
That's the goal. That's true adaptive immunity.
Now, the source talks about how we get this AMI. There's active immunity.
Right. Active immunity is when your own body does the work, makes the antibodies. The best kind is natural active. You get sick, you recover, you have long-lasting, often lifelong protection.
Like getting chickenpox as a kid.
Exactly. Then there's artificial active, which is vaccination. We introduce a safe form of the antigen. Your body makes antibodies and memory cells. Usually needs boosters, though.
Okay, active is making your own. What's passive?
Passive immunity is basically borrowing antibodies. It's immediate protection, but it's temporary because your body didn't make them and won't remember how.
Like antibodies from mom.
That's natural passive mother to fetus across the placenta or through breast milk, short-term protection for the baby.
And artificial passive.
That's when we inject ready-made antibodies. Things like tetanus antitoxin or maybe convalescent plasma for something like COVID-19. It's used when you need to neutralize a threat right now. Doesn't last long.
Critical distinction. Active is long-term learning. Passive is short-term borrowing.
You got it. Now, the other arm of adaptive immunity, cell-mediated immunity, CMI, or cellular immunity.
This involves the T cells.
T lymphocytes, yes, and also natural killer NK cells. CMI is like the command and control center. It regulates AMI, it regulates inflammation, mainly through signaling molecules called cytokines.
So different types of T cells have different jobs.
Big time. You have the helper T cells, also called CD4 plus cells. Think of them as the organizers or conductors. They secrete cytokines that boost the activity of almost all other immune cells. They really ramp up the entire response.
The amplifiers. What else?
Then you have the peacekeepers,
Right.
the regulator T cells, or TREGs. These are incredibly important. They release inhibitory cytokines.
To calm things down.
Exactly, to prevent overreactions and, critically, to stop the immune system from attacking healthy self-tissue. They're vital in preventing autoimmune diseases.
Maintaining that self-tolerance we started with. Okay, what about fighting infected self-cells?
That's the job of the cytotoxic T cells, or CTLs. If one of your own cells gets infected with a virus or parasite, the CTL recognizes it, binds to it, and delivers a lethal hit, triggers programmed cell death.
Targeted killing of compromised self.
Precisely. And then there are the natural killer NK cells. These guys are fascinating.
How so?
They're like special ops. They conduct seek and destroy missions against unhealthy self-cells, especially tumor cells or virus-infected cells, without needing prior sensitization like T cells do. They're constantly patrolling for trouble.
Always on surveillance. Okay, let's connect this back to patient care, particularly thinking about aging. The text makes it clear immunity changes as we get older.
Yeah, it generally declines. Macrophage and neutrophil function slows down, T-cell responsiveness decreases, B-cells take longer to make antibodies. It's a system-wide slowdown.
And this has direct clinical implications, right?
Mm-hmm.
Especially regarding infections.
Huge implications. This is a major safety point. Because of this decline, older adults often don't show the classic signs of infection. They might have a raging pneumonia, but no fever, no high white blood cell count.
Which means diagnosis gets missed or delayed. Very dangerous.
Extremely. So you have to have a higher index of suspicion.
Yeah.
What's the key management advice the text gives for older adults related to immunity?
Reinforce vaccinations. Boosters are essential.
Right. Because their memory cell response is weaker and slower, they need those regular reminders, those boosters, to maintain protective antibody levels against things like flu, pneumonia, shingles.
Makes sense. And finally, let's touch on lab tests again. The WBC differential is key, isn't it?
Absolutely essential for initial assessment. We already talked about neutrophils and the left shift for severe bacterial infection.
Right. What else does the differential tell us?
Look at the eosinophils. If that count is high eosinophilia, your first thought shouldn't be bacteria. You need to think about parasitic infections or significant allergic reactions. It points you in a totally different direction.
So the differential gives you clues about the type of immune challenge.
Exactly. It's like reading the initial battle reports.
Okay, this has been quite the deep dive. We started with that immediate, nonspecific, innate immunity inflammation, the 5 cardinal signs, and the critical importance of the ANC and the left shift for spotting danger.
Mm-hmm. And then we moved into the specific long-term protection of adaptive immunity. We saw how AMI uses antibodies for threats outside cells and how CMI handles threats inside cells and regulates the whole system. You need all three.
And understanding this framework is just vital for recognizing when things are going wrong. Especially, as we stressed, in patients like older adults who might not show those textbook symptoms. It helps you anticipate risks.
Definitely. And maybe a final thought to leave you with, drawing from the text. It concerns CMI, cell-mediated immunity. We talked about it fighting viruses and regulating things.
Yeah.
But its role in surveillance is profound. CMI, especially those NK cells and cytotoxic T cells, is constantly patrolling, looking for, and eliminating abnormal cells. Think about the critical role that plays day in and day out in preventing cancer from developing or spreading after you're exposed to carcinogens. It's this silent, ongoing defense system that's absolutely essential.